And the diagnostic criteria we call them the Rotterdam criteria. And you need 2 out of 3 things to meet the criteria, and then it can't be caused by anything else. So the 3 things are irregular cycles, high levels of male hormones in a woman. So those can be abnormal hair growth on your face or your body, acne, or high blood levels of testosterone or other male hormones. And the third thing is an appearance consistent with PCOS on ultrasound. And if you have 2 out of 3 of those things, and we've tested you for other possible causes of those symptoms, other hormone disorders, for example, then we can make the diagnosis of PCOS by exclusion.
If you have ovaries and you're trying to get pregnant or would like to have children in the future, you need to learn about PCOS. I know a lot of people don't think they need to learn about this. If you're a heterosexual couple, you think that you can try at home. If you're a single mom to be or lesbian couple, you think you just need sperm. But this is an underdiagnosed problem that happens to so many people. 1 in 6 women have infertility issues. And as you get older, the issues increase. So it's so important to make sure that you know about this early on so that you can treat it. And there is a treatment. There are many treatments, in fact, and there's lots of ways that you can handle this problem early on so it doesn't cause you problems later when your eggs are getting older. So please get this information. We have a wonderful guest today who's going to tell you all about it. So let's dive in. From our Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. As the leading destination for support and education for people using reproductive medicine to grow their families, we cut through the noise to provide you with research-based information, effective and actionable strategies, and the support that you need to feel better, so you can get into the driver's seat of your life and build the family of your dreams. We look forward to seeing you inside. Welcome to a new episode of the Building Your Family podcast. Today, I am so excited to introduce you to someone who's going to share with you information that's so important. I'm getting a lot of requests about the topic of PCOS, and our guest today is going to answer all of your questions because I've got them all written down. Her name is Dr. Kristen Cain. She's a board-certified OBGYN and reproductive endocrinologist, and she's worked in infertility since completing her fellowship in 1995. And she's done so many things all over the country. She worked at Stony Brook in Long Island. She built one of the largest practices in Long Island at the time. She's also worked in the Carolinas and in North Dakota and Minnesota and so many other places. She's been in the who's who of American colleges and universities. She has lots and lots of credentials and also awards. And she specialized in so many areas. And now she is helping to build a couple of new programs for Kind Body and is also practicing as a physician. So for a very long career, she's done many things and is the perfect person to teach us today about PCOS. So welcome, Dr. Cain. Thank you so much for joining us.
Thanks, Lisa. Thanks a lot. It's really a pleasure to be here.
So could you tell us a little bit, just to start, what is PCOS and how do we know that we have it?
So PCOS is a metabolic disorder and also can be an ovulatory disorder. So there's 2 sides to it. And the diagnostic criteria we call them the Rotterdam criteria. And you need 2 out of 3 things to meet the criteria, and then it can't be caused by anything else. So the 3 things are irregular cycles, high levels of male hormones in a woman. So those can be abnormal hair growth on your face or your body, acne, or high blood levels of testosterone or other male hormones. And the third thing is an appearance consistent with PCOS on ultrasound. And if you have 2 out of 3 of those things, and we've tested you for other possible causes of those symptoms, other hormone disorders, for example, then we can make the diagnosis of PCOS by exclusion.
So, just for everyone out there, what does it mean when you see what looks like PCOS on your ultrasound?
In PCOS, what happens is women have eggs and they have normal hormones from their brain to stimulate the ovaries to ripen the eggs. But what doesn't happen is the signal inside the ovary, which is a big part of it is a hormone called insulin like growth factor in the ovary. That's sort of a traffic cop. And what insulin
Hmm.
like growth factor does is it selects one follicle to ovulate and then tells the other follicles that are available to go ahead and die off. We don't need them. And follicles are the fluid filled sacs that contain the eggs that we can work with right now. What happens in PCOS is because women don't ovulate predictably, that hormone signal gets messed up. So the eggs tend to accumulate in the follicle at sort of a half grown state. So we see lots of tiny follicles in the ovary on ultrasound.
And so what does that mean? What is the traffic cop doing when that happens?
So, what the traffic cop does, insulin like growth factor, is it selects a follicle to grow bigger and to be more responsive to the brain hormone FSH to grow, and then more responsive to the other brain hormone LH that causes ovulation. The problem with PCOS, and one of the things that we see is a metabolic side to it, where women gain weight more rapidly, they have more trouble losing weight, and they become what's called insulin resistance. So that's a little bit different story. Normally, if you eat something, your body knows from past experience about how much of that you're actually going to use. So, say
Hmm.
you eat a donut and your body says, well, Kristen's only going to burn like 25 calories of this 400 calorie donut.
Oh
So
no.
we need to store the rest as fat, and it releases insulin to do that. In insulin like growth or insulin resistance, what happens is the pancreas is overwhelmed by the demands on it. It continues to make insulin at very high levels, and the fat cells are not able to process the sugar fast enough. So they kind of put the rope up and don't allow more sugar to be stored as fat. So the pancreas just keeps pumping up more and more insulin. And then finally, the fat cells give up. They open the doors, they grow bigger, they make more of them so that they can do this, and you gain weight.
Wow.
So we see that with PCOS quite a bit. And what happens with the insulin like growth factor is because of the name, you can tell it looks a lot like insulin. So if you have high levels of insulin in your body, it can block the sites where insulin like growth factor is supposed to work. So what happens then is the insulin like growth factor can't do its job. It can't tell one of the follicles to ripen up because there's insulin in the way, blocking those receptors.
And how does this happen to someone? Is it hereditary or is it lifestyle? What causes this?
There is a hereditary component to it. A lot of patients I have who have PCOS have dads who have type 2 diabetes, and it's really interesting that it's the dad. Like, it can be the mom, but it's so common to see a father of a PCOS woman with type 2 diabetes. So I do think
Wow.
there's like a father to daughter transmission here. And so there is a family component to it, but lifestyle can make it worse. A person who has a tendency to have PCOS might not manifest all the symptoms of it until she gains weight. And then at that point, she's starting to experience the symptoms. She starts to have, irregular cycles. She starts to notice some chin hair, things like that.
And what age do people usually see that? Is that when they first start to have their periods or is it after?
It really is variable. You can see it in young girls from the time that they first start menstruating, or maybe their first period is really late and that's what's going on.
Hmm.
Or it can start to manifest later in a woman's 20s or 30s after a significant amount of weight gain that wasn't there before.
So someone could have regular periods in adolescence and go through life kind of normally, and then all of a sudden this happens.
Yeah.
And maybe they just think, oh, I'm gaining some weight, or maybe I have some chin hair, or maybe I have irregular periods, and they have no idea this is PCOS.
Yeah, I have a family member who was a three-sport athlete in high school and totally regular, no problems. And then when she went to college and was studying and not exercising as much, because a high school athlete is exercising 2, 3 hours a day. And
Yes.
when you're doing three sports, you're doing it all year long. And all of a sudden, the PCOS symptom, weight gain happened, and then the PCOS symptoms became very apparent.
So exercise could keep this in control.
Somewhat. I mean, you can't out exercise a bad diet, but maintaining a healthy weight does help a lot of people to avoid some of the worst symptoms of PCOS. It's not the whole story because there's a type of PCOS called lean PCOS.
Hmm.
And that's a situation where you get all the symptoms of PCOS except the weight gain and the metabolic piece. And I kind of feel like at some point we're going to discover that those are actually two different diseases
Oh,
with some similarities, but we haven't made that discovery yet. This is just a guess.
and what is your guess? What do you think that that might be?
I think it's going to turn out to be two different things with different things that cause the problems and different things that will help with treatment. And I do notice that my treatment protocols are a little different from lean PCOS and classic PCOS.
And so when someone says, I'm not sure why I'm not getting pregnant, I have irregular periods, or maybe they've always been a little irregular, but it
Mhm.
doesn't look so strange. Maybe I don't have all of those symptoms because I'm not overweight. How do I know that I have PCOS?
So the first thing is, take a look at what your cycles are doing. Are they predictable? A lot of women will have a little bit of a regularity and a range, but a normal menstrual cycle should be between 25 and 35 days from the start of one period to the start of the next. Less
Hmm.
than 25 days makes me wonder if you're making enough progesterone after you ovulate or if you're even really ovulating. And longer than 35 days also is consistent with an irregular cycle. So you may not be ovulating with that either. So that's the first sign. And if your periods aren't regular like that, that's something worth exploring a little bit with your doctor. Another thing is if you do an ovulation prediction kit and you never get a surge, that's a sign. So a surge is when you do, say, one of those kits where you pee on a stick
Hmm.
and you never get the color change, that can be a sign. And another sign of potential PCOS is you get that second line, but it never is really very dark. And so it just kind of is always there through your whole cycle. And ironically, that can be a sign of PCOS too, because what it's measuring is LH hormone. And LH hormone is the brain hormone that's supposed to be low all the time, except in the middle of the cycle, it spikes really high to tell your ovary to ovulate the egg. With PCOS, sometimes LH hormone is higher than FSH hormone, and it just kind of stays that way in a steady state. And so it's always just a little high, and you can see it on an ovulation kit.
So the first step would be, if someone's wondering about that, is if they think I have irregular periods, but I'm not sure, track your periods first and then get a sense of what's going on, and or use an ovulation predictor kit and see if that looks normal to start.
For starters, that's the right way to go. And then if that does seem off, um, you can talk to a doctor about doing a progesterone test a week before you expect to get your period and see if you did ovulate or not. Because progesterone is made by the ovary after you ovulate an egg. It's another hormone. And that's to prepare the uterus to get pregnant, to hold on to a baby. So if you're not making progesterone, then you're going to have trouble getting pregnant. And you won't get a period if you're not pregnant because it's the pregnancy that keeps your body making the progesterone.
The next step would be you would go to your gynecologist, see what your progesterone's like, and if there's an issue, is this something that your gynecologist can help you with, or should you be seeing a reproductive endocrinologist at that point?
It depends on the gynecologist. Some are very comfortable diagnosing PCOS and they have a good understanding of women's hormone levels, and others are more like, I treat infections and do hysterectomies and deliver babies. And this is really kind of not my area. And so if your doctor says, oh, just go on birth control pills and it'll regulate your cycles, well, that's
Yes.
true. It will. But if you want to have a baby, that's not going to work. So, a good idea is, if that's what you're being told, then that would be a good situation to just get a second opinion from a reproductive endocrinologist, because we can test the other hormones that can cause those symptoms as well, and make sure it's not something else.
And now a word from our sponsor. This episode is brought to you by Egg Donor and Surrogate Solutions, a team that is committed to creating happy families with a focus on ethics, experience, and education. If you or someone you know is exploring egg donation, check out their Known Egg Donor program. It's a beautiful and thoughtful approach that allows intended parents and egg donors to know and connect with one another, creating openness, trust, and a foundation for future conversations with donor-conceived children. If you're exploring surrogacy, we invite you to learn more. Their experienced team of previous egg donors, surrogates, and people who've used egg donation and surrogacy to build their family are there to support and guide you every step of the way. Egg Donor and Surrogate Solutions have been helping people build their families for 18 years. They believe in a quality match, transparency, and community. Whether you're hoping to grow your family or you're considering becoming a surrogate or an egg donor, visit createahappyfamily.com and visit their podcast called Me, You, and Who to hear inspiring stories. Now back to our episode. So is the traffic cop not letting the eggs be produced?
No, the traffic cop is on a coffee break. It's more like he's not
That's
able to
great.
do his job.
That's so funny. So what is happening to him that he can't do his job?
This hormone, insulin-like growth factor, is made by the ovary and lives there, but insulin's all over the body. So it's made in the pancreas, it's in your bloodstream, and it goes through the bloodstream to everywhere. Not only to the fat cells to make them grow, but also to the brain, also to the ovary, where it just fits. It's like putting in a bad key in a lock. It's the same brand, but it doesn't turn the lock. It does that.
Hmm.
That's a hormone receptor complex, is when the hormone binds to the receptor, it fits, but it can't make it act. And so insulin's like a bad key in the lock, and insulin like growth factor can't go in there then.
Now, if that's the case in PCOS, can that be true in other places? I know this is not specifically about PCOS, but let's say someone has a diet that's full of, refined sugars and things like
Mhm.
that, or too many carbohydrates. Could that impact their fertility?
Yes, it can. And we know from studies that women with PCOS who follow a healthier diet and an exercise program for a few months have higher success rates, even if they don't lose a single pound. So, improving your diet does make a difference. Improving exercise, sleep. Sleep's really important, because people who sleep poorly tend to gain weight. They tend to be more insulin resistant. They tend to be at higher risk of developing type 2 diabetes and hypertension in the future. So, sleep is really important as well.
Why does sleep cause all those problems or the lack of sleep?
I'm not 100% sure. I'm not a person, but I know that it does seem to be important to reset the body. The rest is really important. And so I do know from studies that it is really important. People who sleep poorly, have a lot of interrupted sleep or short sleep, uh, tend to hold on to their weight more. And we also know that sleep apnea and obesity are sort of a vicious cycle as well. You know, if you're overweight, you tend to have more problems with sleep apnea. And if you have more problems with sleep apnea, you're not going to sleep as well, and you're going to have more problems with being overweight.
That's so interesting. So it's kind of like a vicious cycle. And it sounds like there's some things that we can do to help it. And one of them is exercise. Are there other things that people can do?
Yes, there's supplements that people can try. So, my favorite supplements for PCOS are myoinositol and acetylcysteine. I like both of those because they help make people more sensitive to their own insulin. There's another one called berberine that it acts like a natural appetite suppressant. And then there's medications as well, like metformin, which is a diabetes drug that works very well to help people be more sensitive to their own insulin. And some people even go from not ovulating to ovulating on metformin.
Wow.
And then the GLP-1 medications are really helpful for losing weight. And if you're trying to get pregnant, you may still need medication to help you ovulate, fertility pills to help you ovulate. So it needs to be customized to what you need and what your goals are. Are your goals to lose weight? Are your goals to help with hair growth and acne? Are your goals to get pregnant? And sometimes those goals are mutually exclusive. Like we have to focus on one and then we can address the other one.
So there's a multi-pronged approach, and your reproductive endocrinologist can really help you with all of those things.
Yes, they can recommend a personalized approach for you depending on what your goals are.
And what about so much that's been said about the stress of it, of course, feeling behind in terms of not being pregnant with your friends and all of the things that we experience in infertility, but also that it seems like more PCOS patients experience depression.
Depression is linked to PCOS, and I don't know if it's partly the biological and metabolic part of it or if it's a reaction to the circumstances that they find themselves in, having difficulty getting pregnant, not keeping up with their peers, gaining weight and having trouble losing it. I suspect that there is a biological component because it is so common, but we don't really know exactly what that is yet.
And so, for those patients who feel depressed, is it safe for them to, let's say, start some antidepressant medication, maybe an SSRI or something like that, as they're going through treatment?
Yeah, absolutely. And some of those can even help with appetite suppression as well. Certain SSRIs are great for that, like Wellbutrin tends to cause a little bit of disinterest in food, and so that can be really helpful.
So people really need to understand that these things are a normal part of PCOS, that if they have trouble losing weight, if they have facial hair, if they're feeling depressed, if they're having trouble with their cycles, that they really have to understand this is a natural part of PCOS. There's nothing really significantly wrong with them.
Yeah, I would say so. It is a chronic condition, and a lot of people think, well, you know, PCOS gets cured by menopause, but you still have the metabolic piece that doesn't change. Just the
Hmm.
only thing that changes is that you're not worried about not ovulating anymore because you're menopausal. You're not going to ovulate anymore. But you still can have some of the metabolic issues, even if you're not having like the androgen problems, the male hormones made by the ovaries as much. So that part, you know, can be lifelong and it's something to be managed, but it can be managed with a combination of lifestyle
Hmm.
and medication, depending on, you know, where you are and what your goals are and how you're presenting, how severe it is.
So it really sounds like the best idea is early intervention. And that's the best intervention, just to get to it early.
I think that does help. You know, we all know that when you gain weight, the longer you have it, the harder it is to shift. So I think that does matter. And I do think that's important. But also understanding your body is really important. And no matter when you're diagnosed, I see a lot of people who are diagnosed not until their 20s or even 30s, or it just doesn't really become as symptomatic till then because,
Hmm.
maybe a woman had a baby, no problem. She was ovulating. She gained 80 pounds with her pregnancy. And then postpartum, now she's got PCOS, like
Oh,
full
wow.
blown, because she just never was able to lose the baby weight. Even if you're presenting later in life with that, it's not too late to try things to improve things. We have a lot of options, a lot more than we even had 5, 6 years ago
Oh, wow.
to help people, like the supplements that we use. The GLP-1 medications are now, I don't know, third, fourth generation. They're better than they were a few
Hmm.
years ago. Easier to tolerate, they work better, and those can be great when you're not, actively trying to get pregnant, or even for a short time to just kind of get yourself set up so that you're going to be more responsive to fertility meds, and then you stop them and start trying to get pregnant and can go back on them after you deliver.
And this is so helpful, Dr. Cain. I can't tell you because I think that so many people approach their baby making years thinking about maybe the one problem they have to fix, right? If there's,
Mhm.
a lesbian couple, they think we need sperm, or maybe a heterosexual thinks we need to have sex more often,
Mhm.
or, whatever it might be. It's so easy to kind of focus on one thing. But this is something that we really should be looking at and try to rule out early on so that we can get treatment if there's an issue.
I think you're right, Lisa. And one of the things that, you know, drives me crazy is there's this old school of thought out there that people shouldn't really call themselves infertile and they shouldn't go see a reproductive endocrinologist unless they've been trying for a year to get pregnant.
Right.
And then they changed it to 6 months if you're over 35. But really, if your cycles aren't regular, you might not be ovulating at all. And maybe you should go find out if you know this about yourself. Maybe you should go get checked out sooner rather than later and just see what's going on. Are you ovulating or not? Is this a problem? Are you going to need help with that? And women with PCOS do ovulate from time to time. The problem is it's not predictable.
Hmm.
So if they're not having sex every other day routinely, because they're busy or they're tired
Hmm.
or their husband's busy and tired or not available. If they're not able to do that, it could be, they can waste a lot of time trying to time things that can't be timed.
Yes, yes. And that's so important because it's natural for people want to start slowly, but the truth is that nature is not always kind to women, unfortunately, or people with ovaries, and so we really should try to assess these things early so that we can get on them.
And the other thing is with people who are using donor sperm, if they know they need sperm and that's their only problem, like you said, they still can be really blindsided if they find out that they have a fertility problem as well. And if you're
Yes.
under 40, your odds of having a fertility problem are 1 in 6. 1 in 6 people are
Yes.
going to have trouble getting pregnant. If you're over 35, it's 1 in 3. And if you're over 40, 2 out of 3 people have trouble getting pregnant. So just because you don't have a regular source of sperm doesn't mean that you don't have fertility problems as well. You have the same risk as anybody else.
Yes, so well said. I'm so glad that you're really emphasizing that because it's so important for our viewers to think about that and to think about what they can do to make sure they set themselves up for success early and not just slowly roll into finding out that there's a problem when all of a sudden now you're 35 years old and the clock is ticking really loudly. So I think this is great information. Thank you so much, Dr. Kane. I know so many people will be interested in this, and I'm sure that people will be interested in reaching out to you if possible. So, could you tell us where people can reach you?
You can see me as a patient at Kindbody or if I'm not in your state, one of our many fine doctors. We have 27 locations nationwide. I cover our Charlotte and Atlanta office. And also online, I have a website, www.drkristencain.com. So that's Dr. KristenCain.com. My handles on all my social media are at Dr. K. Cain. Yeah, and I've written a book as well.
That's great. What's the book about?
The book is called Doctoring Your Life: The Secret to Merging Medicine and Motherhood While Loving Your Life. And it's about how women doctors manage their time, how they can combine work life balance and find joy in their lives, their careers, and their families without, going crazy, basically. So it's what I learned living the life, and what I learned from doctors who mentored me and taught me all their, tips, tricks, mindsets to be able to be successful at combining these two really important aspects of anybody's life.
Yes. So important. And of course, something that we're always trying to achieve, right? The work-life balance
Yeah.
always eludes us. And so we'd love your advice about that too. So thank you for everything that you're doing. We really appreciate it and really appreciate your time and all your decades of experience and insight. I'm sure this will be very helpful to our audience.
Thank you so much, Lisa. I love your book. I love your podcast. I tell all
Thank you.
my patients who are going through third-party reproduction to check you out. It's such a good resource for information. So it's an honor to be here, and thank you so much.
Oh, it's our pleasure. And thank you to everyone out there too, because you've taken the time to listen to this. I hope it was helpful to you. And if it was, please press subscribe because that's how we keep going. And we will see you next week. Thank you for joining me today. I hope this was helpful to you. And if you'd like more personalized support, more information, and more education, you can find it in the show notes under the Building Your Family community. We'd love to see you inside. And if you were interested in today's topic, you will really like this video.